So I think the first thing to start this discussion is really the potential issues that we as urologists face once we institute androgen deprivation therapy. So many of the hormonal agents that we start on these patients have major side effects, which includes osteoporosis or bone thinning, as well as a multitude of metabolic complications. It's been my opinion that we as urologists need to take ownership of these complications because we're the ones that actually start the process. So, Dan, let's talk about what your experience in San Antonio as it relates to how you feel, how your group, how you personally manage some of these issues, primarily bone and metabolic issues.
Well, you know, it's taken about, in 1941, Professor Huggins at the University of Chicago determined that testosterone deprivation was effective in prostate cancer care. It's taken us another 60 so years to determine all the metabolic side effects and problems associated with testosterone deprivation. I think urologists now are very familiar with these side effects, including osteoporosis. We have taken a very active approach in San Antonio on how we manage these and feel it's imperative for the urologist to incorporate this in how they manage the patient. We've set up bone health clinics where we have a physician champion, and we also have a physician extender that helps us make sure that we're providing excellent quality of care. We have incorporated not only pharmaceuticals, but we've also incorporated you know, lifestyle management issues, for instance, exercising, avoiding smoking, avoiding alcohol, instituting vitamin D and calcium, and reinforcing to these patients that are on androgen deprivation therapy that there are a lot of other problems, or not problems, but a lot of other issues associated with that care that need follow-up, including following their metabolic issues.
So you've taken ownership of these patients. How difficult has it been to get your partners and colleagues to also have the same understanding about bone issues that you currently have?
Well, that's the primary issue. It's been easier as more data has come out in the literature with regards to the potential side effects associated with these therapies. And so as time has gone on, my partners have accepted the fact that we are inducing bone loss, we are changing the lipid profiles on these patients, we are potentially causing problems with insulin resistance. I think as urologists, we were all familiar with issues like erectile dysfunction and hot flashes, but now we're gaining another understanding. And so over time and over the last couple of years, there's been a big acceptance of this, and doctors in our group are now starting to send patients to our bone health clinic that is managed that way.
Brian, what's been your experience out on the West Coast?
We've been trying to make it a little bit more of an automated process so that if a patient is started on hormone therapy, they're pretty much automatically encouraged to go to the bone health clinic. Somebody's going to check and make sure that they're on calcium and vitamin D. If they haven't had a DEXA scan, urologists in the past never did DEXA scans. So I think that's important to double check and see where a patient is, even when they start hormone therapy, but then down the line when they've been on hormone therapy for a lot of years.
Talk to us a little bit, because I think this is a huge teaching point, which I think many of our colleagues and our partners don't really understand. What does the data suggest in terms of the significance of bone mineral density loss the minute we start patients on androgen deprivation therapy?
You know, I think when we talk about osteopenia or osteoporosis, we're all very familiar with that in women, that as they go through menopause, they have maybe a 1.5% bone loss every year. Men are losing, normal, healthy men, 0.5%, but when you put them on androgen deprivation therapy, they can lose as much as 4% a year, and then that's ongoing year after year.
See, and I think that's a big point, and again, I've always been a big believer, and I think what's happening is that the urologic community is finally, again, taking ownership of this. So, Dan, you mentioned the use of therapeutics. So, educate us a little bit in terms of what is out there currently approved, what's being utilized in this potential space of patients, prostate cancer patients on androgen deprivation therapy, but not necessarily with metastatic disease?
I want to say it was late 2010, 2011. A product by the name of Prolia or denosumab was approved, and it's the first drug for prostate cancer patients or patients on ADT with osteoporosis. It showed significant improvement in not only bone mineral density but prevention of fractures. And so we have incorporated Prolia into our practice. It's given every 6 months. It's an IM injection, or sub-Q injection, excuse me, and it's 60 milligrams. We have that administered by our medical assistants. They come at that point in time, they get their vitamin D and calcium checked, and usually meet with our physician extender and make sure they're complying with all their other lifestyle change issues at that time.
Brian, are you using Prolia as well out in Oregon?
About the same way, using Prolia for patients typically when I've identified that they have osteopenia or osteoporosis, although really anyone on hormone deprivation therapy is a candidate for Prolia.